except cluster headache. And of course, paroxysmal hemicrania attacks look very similar. But in broad terms, to get into those TACs, if you have a couple of the attacks, it's pretty much what you've got. That was our view. Maybe 5's not enough. If you said you thought that was a bit silly, I'm happy to listen to that. We thought 5 is pretty reasonable. But probably that's wrong, I don't mind hearing. It's hard to, you know, once you set 5, someone will say 6 and someone will say 4. And like any one of these things, it's very arbitrary where you set the lines. And literally that was an arbitrary decision. 5 just seemed reasonable. But the weakness, as you say, is you don't determine this periodicity to start. So,
I understand you say that as of now, pending a second study, the Medicare will not pay for the oxygen therapy.
What I said was that Medicare made it clear in a teleconference I was involved, they won't pay for it until the second study's done. But they will help with the second study to provide oxygen for people within the second study. So that, I mean, we could argue with them until the cows come home. I don't, but my view would be it's simpler just to get on and do the second study and do what they want. And then, I understand their position. People like 2 studies because they say, well, one could have just been luck. I don't think that outcome was luck. I just don't get that. Because there was a small study with 10 people, 11 people before. There's a huge clinical experience with oxygen, and that study's really clear cut with a lot of attacks. Okay, I get the issue around doing 2 tropic power studies. I think the simplest thing to do is to just do it. Because it won't take very long, there won't be very many attacks, it's not that difficult to do, and you know, sometimes I think you've got to know which battles to pick, and that's not a battle to pick. You do the study and then go back to these people sound like they're interested in actually being helpful, I have to say. So going back with the second study, I think will really, that will be it, and then we can expect it to go on Medicare. I think it's better than having an argument about it.
So how could this organization help move that along?
Yeah, so when we've agreed the protocol with the Medicare people, I would like to get a posting on your websites to say that the study's recruiting and ask for volunteers. We would want. I would ask you to tell your members about it, I guess, to offer them the opportunity to be involved and perhaps explain to them why it's important. Because I think it's not my business to tell your people why it's important, but I actually think it's one of your roles to tell your members why it's important that the properly controlled studies are supported in cluster headache. That would be a proper relationship. And then we can tell you which sites we're on and get it done, and get back to Medicare with the results. So, you had a question. I think the lady had a question next to the guitar.
This might be an old question, and I'm sorry because I've never had the opportunity to speak to you, and I'm glad to, and I thank you very much for what you do for us. As I said, it's an old question probably, but I just want to discuss the predominant behavioural characteristic of smoking amongst cluster headache patients.
Yeah.
I mean, I'm a chronic cluster headache patient, and I was a heavy smoker. I've recently stopped, but do you think that's a behavioural thing that comes along with the cluster head, or do you think that smoking actually causes cluster headaches?
There's no data. My view is it's behavioural, something to do with the nature of the more complex nature of the problem. I've seen quite young people with cluster headache who didn't smoke and their parents didn't smoke. I've been fortunate in my life to have travelled a little bit. So the argument for that in the Western world is, well, they're all exposed to smoking. Okay. I've seen cluster headache in young people in some really rural parts of India, for example, Maybe they take something else, but they seem to be smoking. That applies to a number of other parts of the world that are not legal. I think the fact that there are clearly people who don't smoke who get cluster headache, it's a question of truth. That there are children who don't smoke, whose parents don't smoke who get cluster headache. And there are people who get cluster headache in cultural settings where smoking is not common at all. It suggests that smoking is not the cause of it. Now, if you have to look at people with cluster headache, look at this brain example, the stimulation. You stimulate an area of the brain that reproduces the behaviour. So, and the behaviour is very, if you look at a video of someone with a cluster headache attack, they're either basically crazy or they've got cluster headache. With all due respect to people, I mean, you know that and I know that, so I may as well say it.
Yeah.
You don't look like, it's not like you're calmly sitting watching the telly. So there's it's a very patterned behaviour. It's very similar in all languages and in all cultures I've ever seen it in. That means it must be quite fundamentally driven from the brain. The other thing is that there's a group that are very, I would say, well motivated, quite determined group of people as a group. I suspect that the smoking problem, taking it up, or indeed having trouble stopping it, is part of the general behaviour, is part of the sort of general behavioural biology around the disorder, as opposed to smoking causing the chemicals out of smoking causing the problem. I think that's probably right. We don't know. That's how I've come to that conclusion. You're not to be blamed for smoking, but to be encouraged not to. It's like a little pact, isn't it? I say all the people look after with cluster headache. If we can stop your attacks, maybe it'd be smart if you stop smoking so you can have a longer life with less attacks. It's like a good deal. You don't want to kill yourself after you stop the attacks. That'd be really cool.
Well, I know, I've reduced my smoking from, in November I was smoking 30 cigarettes a day. I just didn't realise how many I was smoking. And now I've gone down to 5. And my number of attacks is
36.
Good. I think we'll find as many people who don't smoke at all whose attacks still continue as those who. I can find those for you. I'm pleased if you have less attacks, and I'm pleased you don't smoke. And if you stop smoking and your attacks went away, good luck to you.
Yeah.
And if everyone stopped, but I can't. Again, I couldn't put my hand on my heart. I'd love to, but I can't put my hand on my heart and say to a person with cluster headache, if you stop smoking, it'll get better. That would be disingenuous. There's nothing worse than setting an expectation, particularly in a condition like this, and having it fail. That's not fair. But I do think that if you control the attacks better, stopping smoking smart so you can have better quality, longer life, that's smart. Excellent. So,
CMS studies, I want to go back to what we were talking about right before Jane did and address Bill's comment here about this thing about recruiting patients for a oxygen study for CMS. Is it correct? What CMS wants are Medicare eligible Medicare beneficiaries in the study.
They want a suitable number of them. They haven't specified what suitable is, but they do want to see more Medicare eligible people who be eligible for Medicare benefits in the study. That's where your group can be really helpful, because we're going to obviously need to identify them. The worst thing in the world would be to go back with another study and say, well, there's not enough Medicare beneficiaries in here, and that would be really bad. So that's where we're going to need some help to find people who are appropriate to go in the study, so we don't shoot ourselves in the foot. You're right. It's not going to have to be 100%, but it's going to have to be more than the small number that were in the last study. Because one of the biggest problems you probably appreciate is that if we only had people over the age of 65, there's probably less people with cluster headache over that age group. The other problem is for rescue therapy, the triptans are contraindicated in people over the age of 65. So that's kind of catch-22. If you're trying to do a study, if you're trying to recruit people into a study where the the rescue therapy was something you can't give them